Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Get CME for this episode by clicking on the CME link in the show notes. Today, we welcome back Heather Finley Moriali. She's a pediatrician, and today we're going to talk about why doctors are not comfortable with disabled patients. Heather, welcome back to the show.
Hi, thanks for having me again.
Now, for those interested in hearing Heather's story, just go to kevinmd.com/podcast. In the upper right corner, there's a search icon. Search for Heather's name to hear her prior episode and story. But today I want to talk about your Kevin MD article. So you talk about how doctors in general are not comfortable with disabled patients. What kind of studies have been done to show that? And what kind of personal anecdotes can you share that could really illustrate that?
Yeah, so data on things like healthy preventative behaviors, things like cancer screening, show pretty big disparities for people with disabilities. And then there is a physician here in Boston, Lisa Iazzoni, who did a study just this fall that came out, and she queried mostly primary care doctors about how comfortable they were with patients with disabilities, whether they were welcome to their office, things like that. Because she herself uses a wheelchair and had run into some experiences on her own, as have I, that I'll talk about as well. But she found that only about 40% of doctors were confident in their ability to give equal care to people with disabilities, and only 56% said they welcome disabled patients to their practices. So that means almost half are not welcoming patients with disabilities. And then the second part of her study, she did a focus group where physicians were interviewed, and she was the interviewer, but her wheelchair was not visible on the camera. And they very candidly shared stories of steering patients with disabilities away from their offices. So pretty shocking findings if you really dig into it.
Let's talk more about that focus group and study. So by disabilities, what is the formal definition of that as it relates to that study?
So there's different researchers. There's one figure that's commonly thrown around, which is about a quarter of Americans have a disability. And that's if you include things like diabetes, asthma, things like that. If you have a very inclusive definition, I think a lot of researchers use the CDC definition, which is also the ADA definition, which is if one or more of your major life activities are altered or impaired by a disability. And it can include mental, physical, communication, a pretty wide variety.
So in that study where Dr. Iazzoni was interviewing these primary care physicians, and a good percentage of them said that they were not comfortable with patients with disabilities, did you get a sense of what kind of reasons they gave for that?
I think one of the biggest was not feeling comfortable in their skills. And I think although physicians' career is taking care of people who are sick, I think it's more focused on acute. They come in, they have a cold, they broke their arm, you give a treatment, they get better, they go away. Whereas with chronic illnesses and disabilities, people are not necessarily going to get better, and they're going to have impairments that are permanent. And I don't think there's a lot covered in the curriculum in medical training and even residency on how that changes things.
So in the primary care setting, what kind of unique challenges should physicians be educated on when treating people with disabilities?
I think the biggest thing applies to everybody, sort of the universal design principle of if we make things accessible, it also improves care for everyone else. Because I think the biggest thing is not making assumptions, not assuming that the person who accompanies the patient to the office is, a PCA or a home health aide. It could be their spouse. I find people sometimes assume when I'm in a wheelchair that my husband is my PCA, that, I couldn't possibly be married. I've had people when I go to the medical school assume that I'm a patient and not a professor there. STDs and STD related cancer screening is really low among people with disabilities, partly because it's physically challenging sometimes to do an exam if someone's in a wheelchair. But people assume that people with disabilities aren't sexually active, which isn't true. And that goes even for the case for people with intellectual disabilities. So I think just merely not making assumptions about the person in front of you opens the door to giving them better health care.
And you mentioned also that you have a personal story with your interaction with the healthcare system as well.
Yeah, some is running into assumptions, having to correct that, my husband is my husband and not a PCA and things like that. But I got really sick and was admitted for a central line associated bloodstream infection. When I got discharged, I had some to-do items, to follow up blood cultures, get a referral, things like that. And my PCP at the time sent me a quick, hastily, poorly spelled portal message that I needed to find a new PCP, that she didn't have the quote bandwidth to be my doctor, because I needed to find a PCP that specialized in sick patients. So I guess there's PCPs that are only for healthy patients, and I had unwittingly signed up for one. And then trying to find a new PCP within the same health system, when offices, I think, opened up my chart and saw the problem list, or saw that it actually is in the header if you use a wheelchair. It's in Epic sometimes. Their panels would be full, or they would say, we don't know enough about disabled people to be a primary care physician. So I actually didn't have one for about 6 months. I couldn't get the follow-up that I needed. The infection actually wasn't cleared in the end. So it's a little unclear, if I had had follow-up, would I have had a much better outcome? But I became untouchable, essentially.
So just to be clear, you got a message from your primary care or your primary care's office saying that they didn't have the bandwidth for you?
Exactly. That was the exact word, that I had to find a new PCP. And I needed an order for a blood culture and a referral, and I didn't get either. So I actually never followed up with infectious disease. I was in an HMO. You need a PCP referral. There's no exceptions.
So when you read that for the first time, just share with us what your first reaction was.
I was shocked and a little panicked. I was still really sick. I was, able to be discharged, which doesn't mean I was well. I had a ton of stuff to do, and I felt really terrible. I just didn't even know how I could go about getting any of my discharge care done. It's almost impossible to find a PCP anyway, let alone when you need orders done within a week. So yeah, I was shocked and panicked. I shouldn't have been as surprised as I was, because previously when I was working as a pediatrician and switched my job, my patients needed a new PCP. And so my nurse was calling around local offices, and one office that she called, one that's very well regarded in the community, actually told her point blank, we will only accept your patients that don't have disabilities. We will only take your healthy patients. So it's not even hidden that doctors are screening out disabled patients.
Would they ask up front about potential patients' disabilities?
Yeah, we were asking, can we send, can we give them your name? And they actually said, no, we will not take in disabled patients.
So in those 6 months where you were looking for a primary care clinician, approximately how many offices did you try calling?
I tried, I think 5 or 6. I contacted my health insurer. I contacted the complex patient office of the health system, which is supposed to deal with this problem. They were too full. They were overmaxed. They couldn't help me at all. I just kept hitting wall after wall.
And then when you eventually did find one, was it relatively close to where you were? Do you have to make a trek to see this clinician?
I ended up kind of using physician privilege, and there was a physician who was a PCP that I had met because we both were at the same social function. He was an hour and a half away from my house, and he agreed to be my PCP. And so I had a PCP an hour and a half away across Boston, which is not an easy drive.
So short of meeting someone at a social function and you being a physician yourself, is this experience typical of the patient community who have similar disabilities to you?
Yeah. There's actually a slide I got from the CDC, and it was almost a quarter, I believe, of disabled patients don't have a regular source of healthcare. So it's a population that has a really high healthcare need for the most part, but pretty low rates of having good primary care.
So I understand that you're involved with some research and some programs that can help address this issue. So tell us more about that.
Yeah, so I do a little bit of volunteer work with someone called Dr. Linda Long Balil at UMass Med, and she's been working and teaching healthcare professionals for about 20 years about disability. And so I've been assisting her in some of her efforts. And so one of the things is we got a working group together to come up with some goals and objectives. And then actually next week at the medical school, the first years, all of them, so it's not an elective, it's a standard part of their curriculum, are going to have some didactic content about people with disabilities, actually taught by people with disabilities. And then they're going to have standardized patient sessions, and the standardized patients also have disabilities. So it's a really comprehensive kind of dive in. And then the other effort is when they do their physical exam course, they're taught the extremity exam, and then they're taught how to do an extremity exam of a patient in a wheelchair who may or may not have contractures. When they learn HEENT, they're going to learn about patients with hearing aids or patients who are deaf or hard of hearing. So UMass is integrating the content about disability all along, not as this like extraneous other material, but just as a different variety of normal, not a pathology. So I think that's great. And also other schools in the state are doing the same thing in parallel. So Harvard, Tufts, BU, it's kind of a change in teaching that's going along with the broader focus on diversity, equity, and belonging, actually.
You mentioned earlier one of the key things that practitioners should not do is make assumptions. Can you give us a little bit more of a sneak peek of those didactics? What are some high yield things that practicing clinicians can learn when treating their patients with disabilities?
I would say just walk into the room with a clean slate. Don't assume anything about the people in the room, their relationship, how well a patient may communicate, how well they understand you. And I would just ask questions. Don't be afraid to ask a question. If someone's in a wheelchair, can you stand and walk a little bit? You know, no one's going to be offended by that. Would you prefer to get your post-discharge instructions written? Or would you prefer I verbally give them and maybe you record a voice memo? I would just say make no assumptions and then just ask. And I think patients are perfectly willing to guide their caregivers in how to best meet their needs. And they're really the expert in that.
Other than making false assumptions, what are some other common red flags that you typically see in physician offices?
The built environment is huge. I know some of the offices I've worked in have been very inaccessible to wheelchairs to get in the front door. There's a few steps instead of a ramp. When I visit offices as a patient, a lot of times the automatic doors, if they have them, aren't working. I would say very, very rarely is there an accessible bathroom at a lot of healthcare facilities I go to. Exam tables are often quite high up and don't lower. There are some that lower scales. So I would say the built environment is another huge barrier that can be improved upon.
We're talking to Heather Finley Morreale. She is a pediatrician, and today we're going to talk about how doctors are not comfortable with disabled patients and what we can do about it. Heather, for those clinicians interested in learning more about this, tell us some resources that you could share that they can go to.
I would say to look up the work of Lisa Iazzoni and some of her research into patients with disabilities. And then the New Hampshire and Massachusetts Department of Public Health has a great video on do's and don'ts on interviewing and working with people with disabilities that I think is a great free resource. And it does have CME on it as well.
And my final question, please tell us some of your take-home messages that you want to leave with the Kevin MD audience.
I think the biggest take-home message is to be welcoming of people with disabilities and to approach them with a clean slate and no assumptions and be eager to learn from them and ask questions based on their own lived experience.
Heather, thank you so much for sharing your story, time, and insight. And thanks again for coming back on the show.
Thank you for having me.